Welcome to Grand Rounds for February 2010. Brought to you by A-OPTIC. Today's presentation, OMM Family Medicine Board Review, is presented by Dr. Greg Thompson, D.O. Dr. Thompson is Chair of Osteopathic Principles and Practice at Lincoln Memorial University's DeBusk College of Osteopathic Medicine. And now, Dr. Thompson.
Welcome to everyone. This is Greg Thompson at the lovely snowed-in campus of LMU-DCOM, and we're going to be doing another presentation for A-OPTIC on the OMM Family Medicine Board Review. A couple of things that we want to kind of give for you today is a review of some of the pertinent physiology that will come into play when we're diagnosing somatic dysfunction of the axial skeleton. And we're going to be looking at basic positioning, activating forces to manipulate dysfunction of the cervical, thoracic, and lumbar spine, sacrum, and innominate. Now, I know it sounds like a lot to take on all at once, and so we're really going to rock and roll as we go through the basic outline. And then when we get to the demonstrations, we'll just go one right after the other. I'm going to give you a little extra time on the sacrum. Sacrum is always one of those things that people seem to have difficulty with in both diagnosing and treating. So I'm going to give you what I think is the quick and down and dirty diagnosis of sacral dysfunction, how to do it in 20 seconds or less. And then a different kind of manipulation that you might be used to with the sacrum, which is just a ligamentous articular approach. So we'll hit the cervical spine first. Obviously, the things that we've all been trained in and the things I want you to focus on and concentrate on is the standard TART. You're going to be looking for a patient telling you that they've got a problem there. I'm not just going to have you think about I only treat necks if they are in pain, because you're going to be looking at the sympathetic chain ganglia. Don't forget there are postganglionic fibers coming from the superior cervical ganglia that go up into the head. So for sinus problems, it doesn't have to be at the T1 through 4 region. For sympathetic problems, you can be getting it in the neck as well. So in the cervical spine, a couple of housekeeping things, items. We have the OA. Remember that is not a standard Fryette's principal joint space. The OA side bends to the right, rotates to the left, side bends to the left, rotates right, but there's an extension and flexion component. So you want to make sure that as you treat that, you keep that extra component in mind. Don't forget that sometimes they will call side slipping of the OA joint, and when we side slip to the right, then we are side bending to the left and rotating right, and when we side slip to the left, we are side bending right and rotating left. So that's also a way that you might see it written down or that you might note it in your charts. Remember that C2 is rotational only, and that we should assess this in about 45 to 60 degrees of flexion. Remember that the C2 is responsible for about half of the rotation of the cervical spine. And so to lock out the joints of Luschka, you're going to bring that neck up to almost 60 degrees if the patient can do it to take out the rest of the spine. And then as you rotate their head back and forth, you'll have the opportunity to really get a full assessment of whether C2 is lesioned. Don't forget that C2 and C3 are often sort of hidden under the base of the occiput. So when they're supine, you might need to flex their head a little bit to really get a full palpatory experience of C2 and 3. And certainly don't forget that you're never going to get your finger into and actually be able to palpate the OA. If you do, your attendings might have a problem because you probably have just pithed the patient. Don't forget that Fryette's principles for the cervical spine are that they have side bending and rotation to the same side with a flexion extension component. However, it happens in group curves more often than not. You can certainly get a single dysfunction, but oftentimes they will exhibit type 1 group behavior, but with a type 2 pattern. So something to keep in mind. Remember that the soft tissue techniques for your board review are always going to be something that are safe, easy, quick, and so we'll look at the longitudinal stretch, perpendicular stretch, and then mobilization where you take the head and kind of do a figure 8 traction, and then a suboccipital release. Remember that these techniques are really about trying to get the tissues to relax, either in preparation for a direct technique like a muscle energy or a high velocity technique, or to just simply be draining the issue. If people have a lot of spasm, they're going to get some congestion there. It may be sort of for lymphatics, especially to the lower part of the skull, both the anterior and posterior. and for the cervical nodes. We're really trying to get some extra compliance into the neck. We're trying to get the tissue to be responsive and be prepared for what we are going to do as far as the vertebrae themselves. One of the big things that I want you to remember is that while you're treating the patient's neck, and really truly for probably lots of the other dysfunctions they have, is that if you watch the patient's face, you're going to be able to know, one, if they're uncomfortable with what you're doing, two, if you're in the ballpark of some place that might be tender, and especially, excuse me, when you position them for treatment, be particularly attentive to how they're having their face, because it will let you know that you might have tweaked them in the wrong direction, or that you're not just at perhaps the restrictive barrier, that you're approaching the anatomic barrier. So be careful in watching what the patients do. Longitudinal stretch is just lifting along the long axis of the body. Don't forget, you can either do it just as a straight traction. Oh, and I wanted to apologize. I wanted to give some credit and thanks for the UM-D&J docs up at New Jersey, Dr. Mason, and some of his docs who contributed mightily. And I willfully and with permission took their OMM review and modified it for us. So you're going to see a lot of their pictures there, a lot of their slides, and we got that through the Educational Council of the Osteopathic Profession. We all sort of chipped in our presentations, and so Dr. Mason had this one and threw it in the mix. So on the left there is Dr. Mason being longitudinally stretched, and then on the right you can see where you've got your hands on the paravertebral musculature and putting a straight traction. You can either do that as a static technique or start down low at the bottom of the spine and gently bring your hands superiorly across the muscle. Perpendicular stretch is just giving them a nice rotatory force with some side bending, in that one hand supports the occiput, the other hand on the shoulder, and then as you watch their face, you stretch. Suboccipital tension release should be the money shot for anybody who's got any kind of suboccipital headache, anybody who's got any sort of vagal symptoms. Don't forget that the inferior vagal ganglia sits right under the jugular foramen, and that suboccipital space, or just lateral to lateral to that suboccipital space. And you're going to get lots of issues, say respiratory. If you improve that, you may get some increase in secretion thinness. If they're having sympathetic overdrive, the respiratory secretions will be thicker. So this is a nice way to try and help the vagus to work. It's also going to help just as a muscular tension issue. And don't forget that there are shreds of tissue that actually attach from that suboccipital triangle right up to the dura and to the tentorium cerebelli. So we have lots of direct ability to influence excuse me, that area and the consequences of somatic dysfunction in that area. When we're doing HVLA, and I'll go through some of the techniques on our demonstration aspect, remember that you got to make the correct diagnosis. Now, the beauty of high velocity, low amplitude in the neck, and I know this may sound like heresy to some, but the idea here is that once you make the diagnosis, that you can actually treat either side of the cervical spine. It's not that you can only treat one side. You can only thrust on one side if the diagnosis is to the right, and if the diagnosis is to the left, you can only thrust on the left side. You can actually do it on both sides. You just have to keep in mind what the diagnosis is and which aspect of those three axes of motion that you're manipulating. For instance, if I have a C3 and 4 that are side bent right, rotated right, and in flexion. Now we know we're not going to do extension in the cervical spine. Remember that we always have to protect the vertebral basilar artery complex, and we're not going to extend and run the risk of stroking or interfering with the intima of that artery. And so we want to do neutral if we have a flexed lesion. So we'll come to neutral. And then the typical would be is that we're going to side bend to the right, rotate to the left, and then the rotatory force is the high velocity correction. Well, you can also do the same. You can side bend to the left, which locks up the side bending component, rotate towards, and then move them from flexion to extension. So you've actually engaged two planes of motion, and then instead of a rotatory thrust, you can have a slight side bending thrust, and I'll demonstrate that. So the cervical spine is actually very forgiving if you understand your mechanics. And even if you look at some of the practitioners that were trained in the 40s and 50s and maybe even in the 60s, and your eyes get real wide with the amount of force that they use, as far as we know, there's anybody on record who has caused a vertebral artery dissection or intimal tear, that, as we understand it, is all coming from the chiropractic literature, and where there's more force used. And so the better your diagnosis, the better your localization of forces, the much less amount of force that is required to mobilize the spine, and we'll sort of demonstrate that. Make sure that you recognize guarding. It's very important that as you take the patient excuse me, into where you want to manipulate them, that as you watch their face and as they start to tense, that you're going to have to get them to relax. We've got to get through that muscular guarding, which is common and typical. Remember that you can never do high velocity on somebody. It is an absolute contraindication if you're going to do high velocity on somebody who doesn't want it done. If you're having to talk the patient into letting you do it, no, it'll be okay. Wrong, bad, not a good idea. They've got to be fully invested that you're going to be able to take care of them. And then as you bring them to the barrier and you're watching for guarding and you get them to relax, then you're going to go. You're never going to force somebody who's got muscular tension. Watch their sternocleidomastoid. If it relaxes, then you're probably in the ballpark. If you can't quite get them to relax or you can't get them to take their mind off what you're doing, distract them. And while you're watching their face or while you've got your hands in position, you say, go ahead and just touch your toes together. And the moment they start to move their toes together is when you go ahead and do the manipulation. It's a way to distract them. But again, if they're guarding and locked in spasm, you don't want to do it. I'm going to point out something that maybe a lot of folks kind of don't remember. Oftentimes, when we're positioning people for doing high velocity of the cervical spine, we'll say, okay, so I rotate away, I side bend and then I rotate. Well, if you got a shot of my head, you'll notice that my head is an extension and I'm rotated, but there's no real side bending. So it's really important that when you set the patient up and use the rotation and side bending components, either direction, that the rotation occurs and then the side bending so that you're out of the plane of extension. And we'll demonstrate that in a few minutes. But it'll make you, I think what you'll find is that if you're having difficulty with your high velocity to the cervical spine sometimes, that it's the loss of the side bending component because you've actually done the rotation pretty well, but turned what you thought was side bending into an extension issue and aren't getting the corrections that you'd like. So we'll give you a demonstration of that later on. Remember that the movement is very quick and short. Here at the school we call it the quick quarter inch. It really is, if you're at the barrier, it takes very little, low amplitude, very small amount of motion, which is done with high velocity. It's not a long, slow push over a long amplitude. It really is about the speed of your hands and the shortness of distance at the barrier. And those are the things I want you to remember. Now, we talk about the Wallenberg maneuver. If you're concerned about vertebral basilar artery insufficiency or problems, remember that when you hyperextend them and then side bend them and rotate them, you're much more likely to be pinching those arteries, and you're looking for dizziness, you're looking for nausea, you're looking for any indication that this person is a bad example of who you should do HVLA on. So if there's any question of cervical spine arthritis, if there's any question of previous trauma, there's no reason not to go ahead and, without doing manipulation, put them into a place where you would compromise that wall, that vertebral artery, and see if there's any kind of symptomatology. And if there is, all bets are off using high velocity. So as we'll go through this slide, you'll kind of see the positioning, and I will demonstrate all of this. We can do both OA, AA, and C3 through C7 as we go through it. Now, interestingly enough, in this slide, Dr. Mason's giving us a nice little mugshot. This is the same position that you would do high velocity. You can see that he's got very well rotated, that there is some side bending, and you'll notice the side bending is literally into an anterior position of the body on an AP axis. They've rotated and side bent them upwards, so you'd think it was flexion, but because you've turned their head, it's not flexion, it's side bending. It's also the position that we do muscle energy. With muscle energy, we're looking to lock out two of the planes. We don't side bend left, rotate left, and extend for muscle energy. We only need a couple of planes. So as we demonstrate the muscle energy for the head, remember that the positioning is virtually identical. So the thing that I'll remind you about muscle energy, and it doesn't matter whether it's cervical spine, the thoracic or lumbar spine, that you will take the person, you'll make a diagnosis, you'll take them into the barrier or away from their diagnosis, and I'm going to go through diagnosis here in just a minute, take them towards the barrier and then have them push back to what they can do, or in other words, towards their position of ease. So in this case, if I had T4 that was side bent right and rotated left, I'm going to go ahead and side bend them left and rotate them right, and then have them push back towards their side bent right, rotated left. So I'm going to have them push back towards what they can do. And we'll demonstrate this with Adam in a couple of minutes. But just remember, when you make a diagnosis, the patient will be positioned away from that and then push back towards it. And then muscle energy for the OA. Remember, OA has that flexion extension component, so it's important to, if you're going to side slip a little bit, to add the extension if they're flexed, add the flexion if they're extended, and then have them push back towards where they sort of comfortably rest that joint. So we'll go through those. So that's for the cervical spine. There's your review. Thoracic spine. Same old, tenderness, asymmetry, restriction of motion. Sometimes you're only going to get there not because you really can feel any restriction of motion or you're having a tough time, it's a heavier set patient. There's some tenderness there, and maybe you're just going to find, maybe a posterior transverse process. You're going to look for something that lets you know that you're in the ballpark. Now, whether it's symmetry or restriction of motion, which is the best of all worlds, once you find that restriction of motion, when you go to position the patient either indirectly or directly, it's that feather's edge. You're going towards what they can do for indirect and towards what they can't do. And the moment you get to that edge, that feather's edge of where something binds and doesn't go any further, that's the place to start your manipulation, whether it's muscle energy or high velocity. If you go farther than that, what you've done is engage that barrier and then move 2 or 3 vertebrae down or up, so you're not really at the barrier anymore, and then when you apply a technique, it won't be localized. And so that's really important, especially for your boards. When you find it, make sure that you're monitoring that spot while you're positioning the patient, so the person watching you knows that you understand that that positioning is everything. If you just kind of, okay, I'm going to side bend around, rotate them right, and then, okay, I want you to push back, they're going to know that you're just bluffing them, and it's going to be a problem. So make sure you keep your hands right where they belong. As a reminder, if you get asked this question, Fryette's laws. Now, there are 3, but I've got 2, and we'll talk about the third one in a minute. Group dysfunction, typical for, you can have group dysfunction in cervical, thoracic, and lumbar spine. However, only in the thoracic and lumbar spine do we call it a typical type 1 group dysfunction, in that side bending is in one direction and rotation is to the other. So if we side bend to the right, we're going to get rotation to the left. Remember, that's not quite the same in the cervical spine. And then a type 2 dysfunction, side bending and rotation are to the same side with a component of flexion or extension. Now, the third law is that if you bind 1 or 2 planes of motion, you'll bind the other 1 or 2 planes of motion. So if you bind one plane in flexion, you're going to change how much you can rotate and side bend. So that's how you're finding this feather's edge, especially with muscle energy. If I'm going to induce a change in 2 planes of motion, I'm already changing that other plane of motion to bring them towards the barrier. And as I demonstrate that, we'll go through it. Those are just pictures of the Fryette's laws, so I'll just skim through those, let our man at the top put them in as needed. I'm going to show the seated muscle energy for both thoracic and lumbar technique. I like the technique a lot. I think it's easy to remember. It's easy to do. It's much easier to get the patient to relax, in my mind. And quite frankly, I don't think it takes a lot of remembering, well, if this is up and this is this way and this is that way. You just find it and then you go with it. And we'll show you how easy that really is. And I know that this will just be a review for some of you, but it's important to remember that muscle energy is quick. You get paid well for it. And as long as you're seeing results, and make sure that when you're recording the results in your notes, that if you say you have somatic dysfunction and then you list the areas of somatic dysfunction, and in the plan you say, direct OMT utilizing muscle energy, make sure that you note that you got a change in the somatic dysfunction, that you actually didn't just do it, that you actually had a result. And that's kind of important, that sometimes when you get your charts reviewed, that they'll wonder, are you actually doing anything, or did you just say you did it? 3 areas that we're now going to hit. We've got lumbar spine, innominate, and sacrum. Now I'm going to kind of cruise through the lumbar spine and nominants because these are pretty straightforward. Then we'll spend a little extra time on the sacrum, and then when we get to the demonstration, I'll show you how really quick and easy it is to not only to diagnose the sacrum, but also to get right in there and treat it using a way that I'm going to bet some of you maybe haven't seen and may like a lot because it's quick, it's easy, and it gets the job done. So remember that when we are diagnosing the pelvis, lumbar spine, sacrum, you got some landmarks. You got some things that you need to do to be able to isolate where the problem is. So we've got the ASIS compression, where you get on the ASISs and you compress from anterior to posterior, and you're really looking for resistance. Whichever side of the sacrum is bound or jammed at the sacroiliac joint, you're going to get resistance to the push. If you haven't been practicing this for a lot, you might want to practice it a bit, but it will give you the side of jamming. So you can also check the heights of the ASIS and look for symmetry from the midline. Is one more flared out? Is one more in? If you're thinking that it's an in flare and out flare, you might want to just lift up the patient's shirt and get a shot at their umbilicus so that the person evaluating you knows that, that the distance from the umbilicus or from midline, you have something to qualify or quantify that there is, in fact, a distance discrepancy. You always want to check the pubes. I can't tell you how many times I'll see residents or students where they'll say, you know, patients get back pain and they'll do the ASISs and they'll do the PSISs and they'll do the sacroiliacs and the sacral sulci and the ILAs, and nobody bothers to check the pubes, and they can't, and they say, well, this stuff doesn't work. Patient didn't get better. Well, it's because you missed an easy pubic shear, and if you don't fix that, all the stuff that you're doing is going to be oftentimes for naught. So make sure you check the height of the pubes, and after you've done that, ask the patient to flip over. PSISs, palpate. Don't just say that's where they are. If you need to, follow the iliac crest down the sides of the PSISs. Slide your fingers from the top of the PSIS down into the sacrum, the posterior aspect of the sacrum. For the sake of argument, and I know that this may be legitimate in some circles to argue, we are going to use the idea that the sacral sulcus is deep on the side that has the greatest distance, and I'll do this on camera, the greatest distance from the top of the PSIS to the posterior surface of the sacrum. So if I go from the PSIS to the sacrum on this side, and I go from the PSIS to the top of the sacrum on this side will have a more prominent PSIS and will be considered the deeper sacrum. Now, you could say, well, the sacrum tilts and maybe that might get screwed up. It may, however, I've been doing this for a long time, and I can't remember more times on maybe one finger that maybe wasn't the case. You're going to get the mechanics of the sacrum are going to show you that deep sacral sulcus on the side of the high PSIS by far and away the majority of the time. So we check that. We check the lumbars. Now remember, someone may ask you this question, if the sacrum is rotated to the left, what can you tell me about L5? It's going to be rotated to the right. Remember that the sacrum and L5 always rotate in opposite directions. If the sacrum is extended, L5 is generally going to be flexed and vice versa. And we're actually going to use that to our advantage when it comes to treating, especially the posterior or the backwards torsions and the extended unilateral shears. So we got the sacral sulcus, ILAs. Remember to go far enough down the sacrum so that you are truly on the ILAs, or even feel it's reasonable to come down off the ILAs to come into the soft tissue and then come back up to see which ILA is more inferior. Remember that inferior goes with posterior and anterior goes with superior on the ILAs all the time. We never get a posterior superior ILA. It's always hooked together. So if you either get it as obviously posterior or obviously inferior, you've got the mark that you're after. All right, so there's the review of the pelvis as far as the landmarks. Now lumbar techniques. You can do an HVLA lumbar spine lumbar roll. Well, as we are on the table, we'll go through some of the mechanics that I want you to remember, and that will allow you to do it from either side. Remember that no matter what the dysfunction is in the lumbar spine, it can be done from the right or left side. You just have to remember which way is side bending and which rotation you have to take into consideration, whether you use the long axis and maybe up by the arm rotating them, or maybe taking the rotational component with the short axis and the pelvis. And we'll go through that in just a minute. You also can do the exact same thing with muscle energy, put them in the position of a high-velocity lumbar roll, as pictured here with Dr. Mason, and then have the patient push back against your resistance, and then stretch them further into the barrier, and then have them push back. So again, another way to do sort of muscle energy. My favorite way to do muscle energy is the seated position. I love to do it with women who are pregnant, patients who just have a lot of pain getting up and down. There's no reason not to take advantage of that. Innominates, again, we're going to have the ASIS, PSISs to give you a clue. I've got a little chart here to help you with lateralization. Remember that standing flexion test offers you the opportunity to know whether or not there's both innominate and or sacral dysfunction, and whether there's hamstring tension. So it's not truly specific, but if you then sit them down and the seated flexion test is negative, then you can be pretty confident that you're really looking at an innominate dysfunction, possibly a hamstring issue, but that kind of puts you in the realm of the innominates. So if you just do the standing flexion test and you say, it's a sacral issue or it's an innominate issue, they're going to hit you. They're going to grab you for that. So you're going to need to do both if you're going to do that. When we're looking at the ASISs and PSISs, remember that the innominates rotate forward and backwards. So a inferior or an anterior ASIS is going to be lower, in this case on the right than the left, and then that'll bring the PSIS superior on that side. And so we're looking for, is one rotated forward, or is it rotated back? Again, localized by the seated flexion test or the ASIS. If the ASIS and PSIS are both superior and it's positive on the seated flexion test on that side, then it's a superior innominate shear. And then if it's positive on the low side, then you've got an inferior shear. Let's see, or an upslip. I say shear, you say upslip. So you got that little chart to kind of just remind you of what you're looking at, and then the out flare and the in flare we mentioned. So we can do supine muscle energy for the innominate. As you'll see in this picture, it's pretty straightforward. The innominate's rotated back. We rotate it. It's rotated forward. We rotate it back, and then we have the patient push to bring it back anterior. So remember, the patient's going to be doing what they can do. And then a posterior we'll run through in just a minute. Now, torsions and shears and backwards and forward flexions. So I'm going to take, what time, the clock on the wall. I probably took too much time, so I'll have to do some editing. But this is the part that I really want to hit. Remember that you can do a quick and very quick diagnosis. If both sacral sulci are even and you've got pain, you've got tart in the sacroiliacs, then you've either got a forward and backward flexion or a bilateral flexion, bilateral extension. No big deal. Now you've got 8 diagnoses to make. Here's the deal. If you've got a deep right, or if you've got a deep sacral sulcus on one side and the ILA is inferior and posterior on the other side, you have a torsion 100% of the time. You've now eliminated all of the shears and you're down to 4 diagnoses. If your deep sacral sulcus is on one side and your low posterior inferior ILA is on the same side, it's a shear. It's a unilateral sacral dysfunction. You're down to 4. So you've eliminated the flexions and the extensions, the torsions, and now you're down to the shear. So that's how we get us from 8. So I got a little slide here about sacral sulci, ILAs. You got to remember those. So we're assessing those. Here's the picture on what I just said about deep sacral sulcus and ILA on opposite sides. It's a torsion, and then the shears on the same side. So we got 4. How do we get to 2? If you take the sacral sulcus positions, which one is deep? If the right is deep, then the sacrum is rotated to the left. Okay? If it's deep on the left, it's rotated to the right. You just got rid of 2 potential diagnoses, because if it's a torsion, you've eliminated the possibility, if something is rotated to the left, for it being a rotated right lesion, you're down to just 2. If it's a shear and something's in a shear is rotated to the left, it can't be a shear rotated to the right. So you've gone from 4 now down to 2 in a heartbeat. The last thing that you have to worry about is the position of the sacral base. Is it anterior or posterior? Well, the nice thing is that you can use several different tests. You can use a spring test, you can use a sphinx test, and then you can, if you want, you can even do the seated flexion test to give you a sidedness. But in my mind, if you just use the spring or the sphinx, if you push on it, or if the sphinx, if you push on it and it's negative, it bounces, which is a negative spring test, or you do the sphinx test and the base goes forward, which makes it negative, it's an anterior. So you've gone from 2 to 1. You already know, and you're just going to be writing this down. You've got which way it's rotated, whether the base is forward, and whether it's a torsionary shear. You've gone down to 1. The seated flexion test will help to distinguish the side of dysfunction if you're not quite sure. It's another way to kind of let you know. There's a million ways, and I think I left in the algorithm on how to do all of that. But as we go through in this little blurb that we'll do, I'll show you how to do it on the fly. So those are just some possibilities, and I left you a bunch of pictures that I will just sort of flip through as I'm finishing up here that they can leave in the PowerPoint presentation, and these will be just nice reviews for you, some pictures to have to look back on and compare them with what I'm doing on our patient. Okay, so let's go on and move to our patient. As far as diagnosis of the cervical spine, you're going to make a diagnosis. There are two ways that you can sort of make a diagnosis from C3 to C7. You're going to go ahead and look for rotation of the articular pillars so that they're more prominent on your right or your left. If they're more prominent on the right, we've rotated to the right. So that's one way. Now you can also do the side bending. You can do side slipping. And as I translate the patient's head, if he'll translate to the left, he side bends to the right. If he does not translate to the right, then he's not side bending to the left. So we know that this lesion right here at C4 on Adam is side bent right, rotated right. Then I just need to make sure, go ahead and let him drop his head in my hands. Just go ahead and drop your head in my hands. I promise I won't do anything. And I'm going to go ahead and see if it gets worse in flexion or worse in extension. He's clearly worse in flexion. So he's got a side bent right, rotated right, extended lesion. Okay, so where it's worse, you're not going to name it that. You're going to name it where it goes with ease. So he side bends and rotates to the right with ease, and then in extension, it's much more relaxed. So in this case, if we want to do a high velocity technique, we can do two things. Now, you can, in this case, if he's side bent right, rotated right in extension, and we flex him because we're going to bring him to the barrier, you've gotten one plane of motion. You can then rotate in the other direction, and you can position him so that he rotates and he's side bent in this plane. If I side bent him and then rotated him, now I don't know if you can really tell, but he's in extension. He's not in flexion. He's actually in extension. And in this plane, there's not a lot of side bending. So the essence of this is to go ahead and drop your head in my hands. I've got to rotate and side bend him so his cervical spine is side bent and that he does not have a lot of extension. Whether you're doing muscle energy, in this case, if I were going to go ahead and have him rotate his hand back, his cheek back into my hand, yep, push, and I have him hold. Now, you can say 3 to 5 seconds, or you can be an osteopath and you can have your fingers on the lesion, go ahead and push against my resistance, and you hold it, and while you're monitoring that position, you're waiting for the tissue, and there it goes, starts to relax, and relax. You wait for the tissue to relax. So don't say, and I hold for 3 to 5 seconds. No, don't do that. You monitor the patient's tissue, and then as it starts to ease, you have them relax, and then you position them with a little more flexion, a little more rotation, and you say, go ahead and push against, and you push against them, and you're monitoring with these fingers that you hopefully can see on that, and as they start to shift, you relax, and then you'll take them further into the barrier. So that's the muscle energy of the cervical spine, C3 through C7. It's not going to be any different if we're doing C2. Should be flexed about 60 degrees. Let your head relax. You take him through a full range of motion. He's restricted in his rotation to the right. So in this case, we have the patient do what he can do. So I'm going to go ahead and, while I'm monitoring with this inferior hand on C2, I'm going to go ahead and have him, since he can rotate to the left, go ahead and push to the left, and I have him hold it. And I relax, and I'm holding on to C2 with that finger, and then as it starts to shift, relax. Go ahead and just drop your head in my hand, and I can go a little further. And so you want to do that in flexion because that isolates C2. Remember that side slipping. In this case, I can take and translate his OA easily to the right. It doesn't go nearly as easily to the right, to the left. And so in this case, he's side bent left, rotated right, and then I would want to say, okay, extension, flexion, go ahead and drop your head in my hands, and he's worse in flexion as well. So he's either a side slipped right or side bent left, rotated right in extension. You would then go ahead and if you were going to do a muscle energy technique, we would do exactly what we just did. Or if you're going to do a high velocity technique, you can use the traction on the chin
I'm not particularly fond of that one. I'd rather have your hand up on the occiput. Go ahead and just drop your head in my hand. I'm going to go ahead, if he is side bent left, rotated right, in extension, I'm going to rotate to the left, side bend to the right, give him a little flexion. Now if you just drop your head in my hand, and it just goes. Position is everything. It just slides back into place. Didn't require a lot of force. You just got the planes of motion in line with the diagnosis. That is everything. One last thing on the high velocity for the cervical spine before we go on to the thoracics is that if I make my diagnosis, and I promised that I would show you could do it from either direction. Now we can do the high velocity in this case with C4, which is side bent right, rotated right, in extension. We bring into flexion. We go ahead and, well, he's in extension, so we bring him into flexion, we rotate away, and if he drops his head in my hands, I can then do a rotatory high velocity technique and carry him further. Now, if I want to go the other way, he's side bent right, rotated right in extension, I can side bend him left, flex him, rotate, and if you just drop your head in my hand, now instead of a rotatory force, I'm going to go ahead and encourage the side bending force, which means that my force vector, instead of being rotatory, is going to be more side bending. So and if you could just drop your hand, it's just a side bending issue. Can you touch your feet together for me? Drop your head. So you can drop. See a sternocleidomastoid? Drop your head. He's never, there we go. See, he's never done that before. So it's really about just getting to the barrier and dropping him. And then every time, no matter in your boards, just recheck the patient. Do not just call it good. Put your hands back on him and feel for it. It's like, yeah, it's a little bit better. Do a range of motion if you need to, and you're on your merry way. So I'm not going to review the high velocity for the thoracic spine. You either have been doing that for a while and feel comfortable with it or not. With the muscle energy, you're going to find the patient's spinous processes. You're going to look for dysfunction by oftentimes typically either localizing to their pain or finding the posterior transverse process. Once you find that, if they've got a posterior transverse process on the left, you're going to go ahead and have them flex a little bit and drop their head. Go ahead and drop your head. And I'm going to see what that transverse process does. And now go ahead and straighten up. Straighten your body right up, arch backwards for me, and the transverse process stays the same in both flexion or extension. If it had disappeared in both, or it stayed the same in both, then you've got a neutral lesion. You've got a type 1. In this case, he's rotated to the left and side bent to the right, and that lesion goes all the way to there. There's his, and so he is, if T7, so he's T6 through T4, and he is rotated left and side bent right. Now, if we had found that one spot and we had him bend forward and you say, well, it seems like it's a little bit worse, I'm not really sure, but then I have him straighten up and it disappears. If it disappears in one plane, remember it goes away in the place that he's comfortable with and it gets worse at the barrier. So in this case, let's go ahead and treat a type 2. We're going to say that he was worse in flexion, so that when he leans forward, that transverse process became more prominent and didn't go away. So in this case, we've got a rotated left, side bent left, in extension lesion, because remember it's worse in flexion, so we would label it an extension. So what we're going to do is we're going to bring him up to extension, we're going to bring him back to neutral, and then we're going to go ahead and engage him in a little flexion until I start to feel that process start to grab. I'm then, now remember, since he's rotated left, side bent left, I'm going to then go ahead and turn his shoulders, rotate, just to the point where I feel that engage itself. Now it starts to move. The tension becomes a little bit specific. You start to maybe feel the transverse process below the prominent one disappear, but this one just stays hung up. It doesn't really want to move. I then go ahead and find that. So what I've done is then I've got my rotation. I'm going to go ahead and induce a little side bending until I can feel that, and all I'm doing is just kind of dropping my arm on it. Now, do you have to do all 3 planes of motion? Absolutely not. You only have to pick up, technically, 1 will do it. I try to get the students and the residents to do 2, and then if you can do all 3, it's even better. So what I've done is I've leaned him forward, side bent him, and rotated him to the right. Now I'm just going to ask him, do me a favor, and just kind of gently sit up. Just sit yourself up against me, kind of push against me. So stop right there and hold it. Now I'm monitoring and waiting for that to start to change and move. Now he doesn't have a type 2, so I'm not going to make him push real hard. And as that tissue starts to ease, I'll go ahead and side bend him a little more, rotate him a little more, and I'm isolating. The person watching you is going to watch you focus in on that point. If you take the 3 extra seconds and make sure they see you focusing on that point, it's going to make all the difference in the world. They're going to have much more confidence that you really know what you're doing. And typically what you'll do is you'll have them go ahead and sit up against me, and he'll hold it, relax, and then I'll go ahead and flex, side bend. Again, localizing that spot. So that's the type 2. As a type 1, you're really going to be doing just a little tweak in that. Flexion extension is not particularly important. You're going to find him in neutral where that transverse process is obvious. I'm then, in this case, because he's rotated to the left and side bend to the right, I'm going to go ahead and rotate him to the right and kind of side bend him left a little bit. Now, I can get on that side or I can just stay on this side. And I can kind of tip him until I feel that tissue area right there catch. Now I'm going to go ahead and lift that left shoulder against my hand. Hold it. And I'm just leaning on that left shoulder. And since he has this, now the tissue starts to move and relax. Relax. And I'm going to go ahead and then tip his shoulders a little more. Rotate him a little more to isolate that spot, that group curve. And you want to be on the apex of the curve, not the top of the bone, right on the apex of the curve. And go ahead and push that shoulder towards the ceiling. Because what am I doing? I'm having him rotate back the other way. If I've turned him this way and tipped him this way and he sits back up, he is moving back in the direction that the lesion is, at the place of ease. And then we'll do that until we get resolution of that area. Thoracic spine and a heartbeat. I wish this segment was more had something more to add, but you're going to do the exact same thing, but you're just going to do more of it. In this case, if we have an L2 or an L3, in this case he's a little prominent on that L2. I'm going to go ahead and have him forward bend a little bit, and I'll have to go further because I've got to get down to the lumbar spine. It stays about the same. Arch your back and bring it up. Stays about the same. So he's got one below, and then just 2. So he's got those 2. He's got an L2, L3. We're going to do the exact same thing we just did with the upper thoracic spine. We're going to go ahead and remember that what he's got is he's got a rotation to the left and a side bending to the right. So what am I going to do? I'm going to rotate him to the right all the way down till I get to that, and then I'm going to side bend him to the left until I feel that tissue engage, and then I'm going to go ahead and say, go ahead and sit up right against me. Go ahead and sit yourself towards the ceiling. Good. Hold it. Watch and manage this tissue. Keep watching the tissue with your fingers. As it starts to soften and slide, then go ahead and have the patient relax. Don't just count to 5. It's not always going to get you the lesion. Because it's really important that you've got to kind of play with his shoulders to localize that spot. So right there is moving. Then I'm going to go ahead and side bend him a little bit more till it catches. Rotate him away till it catches. Then say, go ahead and sit up with that shoulder right there. Now, can I be on the other side? Go ahead and sit up against my shoulder. Absolutely, it doesn't matter. It makes no difference which side you're on. As long as you're monitoring and you've got the mechanics of where you want to be, we're going to hold that until it releases and relax. And now I'll go ahead and follow it a little bit more. See, now it's kind of moving. And I'll go ahead and sit him up and reassess, and he's good to go. Type 1 lesion. In this case, we're going to say that he's rotated to his left, just like we did. We got L2, L3. He's rotated to his left. He's in a neutral position. So remember, so that if I aggravate him, this makes his rotation worse, theoretically. Up to down, if I rotate him down to that point, that rotation is going in the wrong direction. Unless when I position his legs in a place of neutral and then take his leg and I'm going to rotate his hip over the top until this rotates towards me. Now what I'm doing when I apply my thrust is that the rotatory force of localizing the forces right there. Take a nice deep breath and let it go. I've taken and rotated this vertebra towards me and the one above it in the other direction. So using the short lever, I've got it in this direction. Now, the thing that I didn't show you and was just kind of pointing out the rotation force is you're going to get rid of side bending. If he's rotated to the left, he's going to be side bent to the right. By taking his arm, go ahead and grab my elbow. I'm going to get rid of his side bending by pulling in a very superior direction and then rotate to just above the lesion, because if I got to the lesion, I would continue the rotation in the wrong direction. Now let's fix the exact same lesion on the other side. Go ahead and flip, turn on your other side. And slide down towards your butt. We good? Okay. Now, in this case, the transverse process, instead of it being up and rotated away from me, it's now down and rotated that way. Now, if we want it to rotate from there to here, then it makes perfect sense that we grab his arm, and as we pull his arm out, ultimately when we get to that lesion, it'll rotate in the direction that we want it to go, which is going to be the restrictive barrier. Now, but there's a difference. Now this time, if he is rotated to the left and he's side bent to the right, if I pull his arm up, I'm going to make his side bending worse. So in this case, knowing the mechanics of that lesion, if I have him grab my elbow, and as I rotate him down to the lesion, I'm then going to go ahead and pull him in an inferior position, so I side bend his lumbar spine into the table and get rid of the side bending component rather than pulling his arm up and making the side bending worse. So the lesion can be isolated from either the patient's side, but as long as you remember where your side bending rotation is, I can then go ahead and rotate down to that spot, and I'm going to go ahead and fix his legs so that they are generally neutral. And I'm feeling, and make sure that you're showing the person that you know what you're doing, that you're feeling. This hip has got to be at least 90 degrees, and then you're going to isolate. You've gotten rid of the side bending rotation. You go ahead and stretch for side bending, increase rotation, and then do your thrust. It's all about isolation. Okay? Now, for type 2, the only thing you've got to keep in mind is that you've got to have your flexion extension. If you have a flexed lesion, you're going to fully extend their legs. Put your legs straight out for me. Relax, go to sleep. I'm not going to do anything, I promise. And then as you find that place where extension grabs it, if you've got an extension lesion, he can extend, so I'm going to flex him to the point where it grabs. Right there's where it grabs. I'm going to go ahead and take that leg, get his hip past 90 degrees. Now, lesion in this case, he's side bent left, rotated left. His transverse process is down, his side bending is into the table. If I've got to get rid of his side bending, it's into the table. Now, with a type 2, and if the transverse process is down, I've got to pull his arm up to get rid of the side bending component. Go ahead and grab my elbow. Get rid of the side bending component down to the lesion. So I've gotten rid of that. Now my rotatory force, as you remember, if his transverse process is rotated in this way, he's down, I can go ahead and rotate him in this direction down to the lesion. So I've gotten rid of the side bending. I've gotten rid of the rotational component. I've taken care of the flexion. Go ahead and let your hips just relax for me. And you're going to go ahead and further the side bending, increase the rotation at the point of, and have the patient take a nice deep breath. Let it all go. Relax your legs. Let your legs drop. And then you go. When they drop, you go ahead and go after it. And you're isolated at that point. Now again, the same thing happens if I want to flip him on his other side. Go ahead and flip. We've now taken something that was side bent left, rotated left, and this time we'll call it inflection. So I'm going to treat the exact, it doesn't matter what side I put him on, I just have to remember which way everything is rotated. So in this case, his transverse process is up, meaning it's rotated up towards us and away from us. So the rotational component, if I pull his arm out, I'll make it worse. So I've got to make sure that when I rotate down to that, I don't grab the lesion. His side bending is now up to the table. He's side bent to his left. I can't pull his arm up. That'll make it worse. If the transverse process is up, I'm going to pull his arm down and rotate him down to that. So now I've gotten rid of my side bending. I've gotten rid of the idea of that transverse process because I can't do it with his shoulder. So I've got to position him in such a way as to take him into neutral, let your legs just relax. I'm going to extend him until I get to the point where the lesion starts to grab. That top leg is just hooked above. Now in this case, because that transverse process is rotated up and away from me, I've got to use the short lever or the hip so that I bring that transverse process right to the point where it is now going to move in this way when I thrust. Take a nice deep breath, exhale, and go. So positioning can be done from either direction, either side, neutral, non-neutral, doesn't matter. For the last few minutes, what we're going to be talking about is how to do a very quick diagnosis of the sacrum and a very quick treatment. I love this sort of protocol because it's just it's near as idiot-proof as you can get, and since I'm pretty close as you can get to be an idiot, then even I can do it. So the first thing you're going to do is stick your fingers into the sacral sulci. You find the PSISs, and you roll from the top of the PSIS down into the sacral sulcus. The most prominent PSIS is going to be the side of the deep sacral sulcus. As you roll in, the greatest depth you fall is deep sacral sulcus. So on Adam, his deep sacral sulcus is on the left. Now I'm going to go to his ILAs. I'm going to tell him that if he has chronic back problems, he can get his wallet out of his back pocket. I'm going to get onto that ILA and find out posterior, and if I'm not sure, I'm going to go inferior till I hit soft tissue and then move my hands up so that I am now able to look with my dominant eye. In my case it's the left, but I've changed sides for the camera. His posterior inferior ILA is on the left. Now what did we talk about? We talked about if the deep sacral sulcus is on the same side as the low and posterior ILA, I've just gotten rid of 6 possible diagnoses. He has a unilateral sacral dysfunction. Okay? So we're down to 4. So we went from 10 to 4 in a heartbeat. If they had been on opposite sides, it would be a torsion. So we're going to go with this. So in this case, he's got a deep sacral sulcus on the left. Which way is it rotate? Which way is the sacrum rotated? It's rotated to the right. Okay, there's only 2 unilateral sacral dysfunctions that are rotated to the right. Either a unilateral left sacral flexion or a unilateral right sacral extension. I'm now down to 2. So I went from 10 to 2 with just knowing what side the ILA and the deep sacral sulcus are on, then which way the sacrum is rotated. Now you've got just 2 choices. In this case, I'm going to go ahead and go to do a spring. If I do a spring test and I say, well, you know, I haven't been doing this very long and I'm not really sure, I'll go ahead and do a sphinx. I'll put my fingers in the deep sacral sulcus, come up onto the base of the sacrum. Remember, when you extend the lumbar spine, the base of the sacrum goes forward. So in this case, Adam, if you could please come up onto your elbows. He comes up onto his elbows. The sacral base should drop. Now remember I said it was deep on the left. Now they're even. So in this case, the base drops on the right to join the left. Well, if the right were posterior and it was stuck posterior, when he came up on his elbows, it wouldn't move. So a sphinx test that's negative means the base drops completely. So if his left is already forward and his right joins it, then the left is forward, he's got a flexed lesion. If when he came up on his elbows that the right side did not even out and it was posterior, then I had my 2 to 1. I had that he was a right unilateral sacral extension because he was posterior. In this case, he comes up on his elbows, they join. He's a left unilateral sacral flexion. Go ahead and drop. It's that easy. That's how quick it is. I mean, you really go from 8 to 4 to 2 to 1 in just a heartbeat. So hopefully that'll give you a little bit of advice on how to do a quick sacral diagnosis. I've left the slides on the PowerPoint, so hopefully that will help. Okay, now we're going to treat both the torsions and the sacral extensions using ligamentous articular technique. So it's really just, I think, kind of a fabulous sort of thing. Let's do the unilateral sacral flexions first, and each of these will take about a minute to show you how. In this case, he's got a left unilateral sacral flexion. He is deep on the left. He is posterior and inferior on the left. We know the dysfunctional side of his sacrum is on the left. Had we done a seated flexion test, it would be positive on the left. I'm going to go ahead and take and abduct his leg just a little bit, and internally, no helping. Don't have the patient help you. Let you do all the work. I'm going to, at his knee, not below his knee, because I don't want to torque the ligaments in his knee, I'm going to gap that sacroiliac joint. I'm then going to go ahead and remember that if this is the dysfunctional side, and it's deep and it's low, I'm going to go ahead and get on his ILA, and I'm going to apply a force vector in a superior way to bring this ILA, I'm going to push downward to induce the posterior ILA to go anterior, and a superior vector to try and bring the sacrum back up into its normal base position. So I'm going to push down to bring the base up, and I'm going to push superior to bring this that's inferior back up into its normal position. So I gap the joint, I push down, I push up a little bit, and I ask the patient, go ahead and take some nice slow deep breaths for me. And then as he exhales, if you remember, as he inhales, the base comes posterior. And so I'll allow him to do that. And then as he exhales, I'll go ahead and lean a little bit to augment, bringing that base posterior, because that's what we're trying to accomplish. And now it starts to slide. And I'm going to go ahead and follow this ILA anteriorly and superiorly as he exhales. And then I finish up and I go back and check. His ILAs are now even, and I go back and check his sacral sulci. Okay, that's the unilateral sacral flexion. Now let's treat this as though it were a unilateral sacral extension. So if he has an extension, he's got a shallow, well, he'll have a deep on the left, a low on the right, but his spring is positive. It doesn't come up. Now in this case, the base is posterior, I've got to make his base go anterior. And if we can, to get the sacrum come down a little bit inferiorly as well. But it's that posterior base that's the problem. So I'm going to take the dysfunctional leg side and gap that sacroiliac joint. I'm going to abduct the leg, internally rotate it a little bit, and go ahead and play with that there. Now, you can do it from either side, but my suggestion is that you tend to do it on the side of the dysfunction, because what you're now going to do, and hopefully you can see it from the other camera, is I'm going to internally rotate his leg to gap that sacroiliac joint. I'm going to go ahead and get inside that PSIS with my hypothenar eminence. So I'm now taking an extended lesion and pushing it anteriorly towards where it's supposed to be. And you can do a couple of things. You go ahead and have the patient take a deep breath. As they inhale, you resist inhalation because that drives the base posteriorly. And as they exhale, you follow it anteriorly. And you're just leaning on that base, trying to get it to slide. Say it won't move. I hate it when that happens. Go ahead and reposition yourself again. Adam, if you could please come up on your elbows. Remember that as they come into the Sphinx position, this is going to push the base of the sacrum anteriorly, or at least encourage it. So I'm going to go ahead in this position, and then go ahead and have him take some nice deep breaths. I resist inhalation because, again, that drives the base posteriorly. I encourage exhalation. I resist inhalation and encourage exhalation. Now, I'm not going to do it real hard because I'm going to create a right unilateral sacral flexion on him if I do it, because he doesn't have the dysfunction. And you follow it until it slides. There's your unilateral sacral extension. So we just got rid of 4 with those 2 techniques. Go ahead and drop. Now for the torsions. In this case, let's say he has a torsion. He's got a deep sacral sulcus on the right, a inferior posterior ILA on the left, and his spring is negative. Now to do that, what's going to happen is I have a left oblique axis. His deep sacral sulcus is on the right. His low ILA is on the left. Here's my axis. And remember that the right is the dysfunctional side. Okay, so a left on left is going to have a right-seated flexion test because the right's the dysfunctional side. Now, remember your axis. Here's your axis that's normal. Here's your dysfunctional, and this happens to be posterior. Well, how about if we just gap his right leg? We abduct, internally rotate, and gap this sacroiliac joint. And remember that this is deep and anterior. This is posterior and inferior. And using this axis, what would happen if I pushed on his ILA? Which way is the sacrum going to rock? It's going to rock on the axis, and it's going to put a force vector that allows his anterior base to come posterior. I'm going to go ahead and do the exact same thing. If I want his base to come posteriorly, go ahead and take a nice deep breath. I'm going to let him do that and push here because I'm driving this base posteriorly. And then as he exhales, and as you exhale, go ahead and push a little more because exhalation causes the base to go forward, so I'm going to encourage on this axis this teeter-totter sort of effect that allows the base to come. I'm going to go ahead and just kind of keep leaning on it gently, wait for things to start to move, and then you'll start to feel it slide and release. You may need a couple of breaths, you may need half a dozen breaths, but again, you're really focusing on using that oblique axis and using this anterior base and this posterior ILA, and I'm going to go ahead and just, as I push, I'm going to rock that back up into place as I've gapped that SI. Okay, there's your anterior torsion. Now how about a posterior torsion? Same exact set of principles apply, except you're going to do it from the opposite direction. So in this case, if we had, well, let me come over here so you can see it on film. If we had a left on left, but his spring was positive, in this case, the only other way that we're going to get something that's faced backwards with a deep sacral sulcus on the right is a left on right. So now the axis has done this. This is deep, this is low, but our axis now is here, and this is the problem. Our posterior has got to go inferior. Okay, I mean, his posterior has got to go anterior, and that's that base, and I've got this axis. Well, how about if I just get on the base and try to, again, do that teeter-totter and using the principles of increased inhalation and exhalation and flexion of his, extension of his lumbar spine to flex the base. So here we go. We've got this posterior base. I'm going to abduct and internally rotate. So I've opened up that sacroiliac joint because this is the dysfunctional side. I'm going to go ahead and find the PSIS, get onto the inside. In this case, I've got my hypothenar eminence right on this the left-hand side of the base of the sacrum. Now I need to encourage flexion of the base. So I can say, go ahead and take a deep breath. and resist it, because as he inhales, it drives the base posteriorly. As he exhales, I go ahead and lean a little bit more. I encourage that. And boy, we do this 2 or 3 times, and he's just resistant. Well, what else am I going to do? Adam, if you could come up on your elbows, please. So I'm still gapping. I'm using this leg to gap it. I encourage the base to move anteriorly based on his position of lumbar extension. I go ahead and internally rotate the leg with the abduction to gap that sacroiliac joint. I put my finger back on, find the PSIS, get on the joint, and then I go ahead and take a deep breath, which, remember, drives it backwards, so I resist that. And then as he exhales, I follow it down and allow it to move, and then I maintain that pressure. As he takes a deep breath, I try to keep my gains, but not so much that I drive him insane with pain. And I go ahead and follow exhalation, and I keep going until I can feel that sacroiliac joint start to slide. Okay, so quick diagnosis, pretty quick treatment. The only thing you got to remember is which is the dysfunctional side. Is it posterior? If it's posterior, you got to lean on the base to get it to go anterior, and you're going to do things to encourage it. If it's a forward flexion torsion, a forward flex torsion, or a forward flexed shear, you're going to do something to drive that base posteriorly, and so you're going to encourage using the mechanics of the sacrum. With torsions, you remember the oblique axis. Remember that oblique axis in that one we just did? You're pushing here, and the axis is here, so we're driving this down. We're going to bring this back and hopefully get him back in line. So remember, on the torsions is an oblique axis. With the unilaterals, you're going to be thinking more in a superior sort of direction. Hopefully that'll help. Feel free to give me an email. Give me a phone call if you need to ask any questions about any things we've reviewed, and hopefully this will get you through what you need. Thanks, you guys. Have a great day, and good luck with your boards.
Thank you for joining us today for OMM Grand Rounds, presented by A-OPTIC. Check out A-OPTIC on the web at a-optic.org.